In this video, we will discuss acquired obstruction of the lacrimal drainage system, including conjunctivochalasis, punctal stenosis, canalicular obstruction, and nasolacrimal duct obstruction, with emphasis on clinical features and management. Acquired lacrimal drainage obstruction can occur at multiple anatomical levels. At conjunctival level, conjunctivochalasis; at punctal level, primary and secondary punctal stenosis; at canalicular level, partial or total obstruction; and nasolacrimal duct level obstruction. Conjunctivochalasis. It is characterized by redundant folds of bulbar conjunctiva prolapsing over the lower eyelid margin. It is common but under-recognized cause of epiphora and is associated with dry eye and chronic ocular surface inflammation. It occurs due to loss of conjunctival adhesion to Tenon's capsule and episclera. Mild conjunctivochalasis can be treated conservatively with lubricants and topical anti-inflammatory drops. Severe cases require surgical treatment. The options include excision of the redundant conjunctiva and suturing the edges together, or securing the bulbar conjunctiva to sclera with absorbable sutures. Primary punctal stenosis. This occurs in the absence of punctal eversion. Common causes include chronic blepharitis, idiopathic stenosis, infections such as herpes simplex and herpes zoster, drug-induced such as topical glaucoma medications 5-fluorouracil, radiotherapy, and systemic diseases like porphyria cutanea tarda. Dilatation of the punctum alone can be tried, but it rarely gives a sustained benefit. Punctoplasty is usually required. A number of techniques have been described, including 1, 2, or 3 snip enlargement with removal of the posterior ampulla wall. Mechanical punch, laser, or microsurgical techniques or temporary stenting can also be used. Secondary punctal stenosis occurs after punctal eversion and leads to chronic failure of tear entry into the drainage system. Treatment is punctoplasty combined with correction of the underlying lid malposition. Management of secondary punctal stenosis. Retropunctal cautery or Ziegler cautery. It is used for pure punctal eversion. Here, burns are applied to palpebral conjunctiva about 5 mm below the punctum. It produces tissue shrinkage and inversion of the punctum. Medial conjunctivoplasty. It is used in medial ectropion. Here, a diamond-shaped tarsoconjunctiva 4 mm high and 8 mm wide, parallel with and inferolateral to the canaliculus and punctum, is excised, and the superior and inferior wound margins are approximated with sutures. Lower lid tightening with tarsal strip procedure. It is used to correct lower lid laxity. When there is significant medial ectropion component, it is combined with medial conjunctivoplasty. Canalicular obstruction. It may occur due to congenital causes, trauma, herpes simplex infection, drug toxicity, irradiation, and chronic dacryocystitis. Partial canalicular obstruction is the partial obstruction of either common canaliculus, individual canaliculus, or any part of the lacrimal drainage system. Partial canalicular obstruction can be treated with silicone tube intubation. The stent is left in situ for 6 weeks to 6 months. In cases of total individual canalicular obstruction, canalicular trephination can be performed using a purpose-made mini trephine such as the Sisler trephine followed by intubation. Another described technique uses an intravenous catheter with a retracted introducer needle acting as a stent to overcome the obstruction. Other less invasive methods include balloon canaliculoplasty and endoscopic laser techniques. However, these procedures generally have lower success rates compared to more definitive surgical approaches. When 6 to 8 mm of normal canaliculus is present between the punctum and the obstruction, an anastomosis of the patent canaliculus into the lacrimal sac can be performed, along with intubation. When the obstruction is severe or when it is not possible to anastomose a functioning canaliculus to the lacrimal sac, conventional surgery involves conjunctivodacryocystorhinostomy with insertion of a Lester-Jones tube. The Lester-Jones tube is a toughened glass tube inserted between the conjunctiva and the nasal cavity. It is also useful when the lacrimal drainage system is intact but non-functioning due to failure of the physiological lacrimal pump, such as in facial nerve palsy. The surgery is performed similar to an external dacryocystorhinostomy. The caruncle is excised and a track is created between the lacrimal sac and the nasal cavity for the placement of the tube. Nasolacrimal duct obstruction. It is most commonly due to idiopathic stenosis. Other causes include trauma, granulomatous disease, and infiltration by nasopharyngeal tumors. The treatment of nasolacrimal duct obstruction is dacryocystorhinostomy. It involves anastomosis of the lacrimal sac to the nasal mucosa and has a success rate more than 90%. Endoscopic dacryocystorhinostomy is performed through a transnasal approach without skin incision. It has advantage of less blood loss and shorter operating time, but a slightly lower success rate compared to external DCR. Probing and intubation, stent insertion, and balloon dacryocystoplasty are reserved for partial nasolacrimal duct obstruction. Dacrylithiasis. Dacryliths are lacrimal stones and may occur in any part of the lacrimal drainage system. They are seen more commonly in males. The exact pathogenesis of dacrylithiasis is unclear. It is proposed that tear stagnation secondary to inflammatory obstruction may lead to stone formation. This process is associated with squamous metaplasia of the lacrimal sac epithelium. Dacrylithiasis typically presents in the late adulthood. Symptoms include intermittent epiphora, recurrent episodes of acute dacryocystitis, and distension of the lacrimal sac. On examination, the lacrimal sac is distended and relatively firm, but it is not inflamed or tender as seen in acute dacryocystitis. Mucus reflex on pressure over the lacrimal sac may or may not be present in dacrylithiasis. The definitive treatment for dacrylithiasis is dacryocysto-rhinostomy. The acquired lacrimal obstruction can occur at multiple levels. The management depends on the level involved. Punctoplasty is used for punctal stenosis. Intubation for canalicular obstruction. Dacryocysto-rhinostomy for nasolacrimal duct obstruction. And Lester-Jones tube for total canalicular block.